Good morning, Mr. Chairman. Thank you very much for your kind introduction, although I know that my name is a little bit different and a little bit challenging to pronounce. And I want to thank the organizing committee for inviting me to this prestigious conference. And I'm very much pleased to be here. So today, my task is to give you a brief and concise review about the impact of older age on local treatment decisions. So my potential conflicts, other than the honorarium, is being an active surgeon, so please take this under consideration. So the first question is that should it be different, the local treatment should be different in elderly. Why we ask this question? Because we're really in a challenging position when we face our patients in young ones and in the elderly ones. Because we have different papers coming, and we are reading that the undertreatment is most likely in these elderly patients. So there are various reports saying that the survival is decreased and the mortality is increased in these patients, and this is mostly due to the undertreatment. Well, this is a causation. Is this a causation or a correlation? We don't know. So let's look at it. The issues that we face when we are dealing with the elderly patients are the competing risk factors, because these are the things that we are really hesitating when we see our patients. And also we think that the tumors in these patients are more indolent than the younger counterparts. And of course, we always consider the life expectancy in these patients. So we know that the functional limitations is increased in these elderly patients, and approximately 50% of those patients at least have minimum one limitation in their daily life before their treatment starts. And also, the comorbidity is very important. This is more in elderly. According to the age cohort, of course, it's a little bit less in 60s, but more in 80s. It's between 40 to 75% of patients have minimum one comorbidity, and it increases as age advances. And this is the same in my country as well. We did a study like 5 years ago, and we found that if the number of comorbidities is increasing, then the substandard treatment is also most common in these patients. And this is also correlated with the systemic treatment as well. So another issue for the surgeons, we are also a little bit concerned about the complications in these patients. And it is certain that the studies that show that the postoperative complications, not the mortality, but they are increased in these elderly patients. And this is also increasing as the age is advancing. So it is something like 15% when the patient is between 65 and 70. When the patient is over 85, this percentage goes up to 25%. Another issue is the biology of the tumor in these patients. And we also observe this in our daily practice, and we believe that these patients are also having the more low-risk cancers. And the trials until now showed us clearly in Europe, in UK, in the States, that if the patient is elderly, we see more luminal A cancers, less HER2-positive and triple-negative cancers. And genomically, it is also true, because among the triple-negative cancer, the basal-like cancers are less likely. And also amongst the hormone-positive, HER2-positive cancers, the luminal B cancers are more likely, and HER2 cancers, positive cancers, are less likely. And again, the same. As age advances, the less we see the aggressive type of tumors like triple-negative cancers. And the last thing, the life expectancy. This is the natural thing, because when you see a patient 80s and you expect less expectancy for the remaining life, that means that later on I'll show you the benefits that you can get from the standard treatments. If this benefit is limited, then it is less meaningful when the patient has a few remaining years until the end of their life. And this is the reality in the whole life, that for the last 50 years, the life expectancy is increasing in every part of the world, increasing in Africa. But still, this is the natural way. When the patient comes to the 80s, for example, in UK, the patient is expected to live 9 or 10 years more. So you have to consider this when you're deciding on the local treatment in these patients. Not only local treatment, of course, also for the overall treatment as well. So I will try to concentrate on 3 issues here, although I'm a surgeon, but I'll just talk about a little bit about the whole breast irradiation after breast cancer conserving surgery as well. So the first issue is the primary endocrine treatment. So we know this is one of the oldest issues that we're discussing since 1980s. There were 7 or 9 studies studied this, but I only took 3 of them. Why? Because in the contemporary practice now today, we are only giving endocrine treatment to those whose tumor is hormone positive. So we have 3 studies. One is the Italian study GRETA, the other one is the UK study CRC, Cancer Research Campaign study, and the other one is the Nottingham 2 study. In all 3 studies, they included patients who are older than 70, and the tumor size is up to T3, not excluding only the chest wall invasion, and also they included their patients who had node positivity. In all these 3 studies, they used tamoxifen as an adjuvant treatment after surgery, also as a primary endocrine surgery. They compared these 2 groups. But only one of them included patients who had ER-rich positive cancers. The other one, the GRETA trial, included patients with hormone-positive patients, but only 80% of them, they found that at the end, because that was not an inclusion criteria, it was found to be hormone-positive. And all 3 studies showed only one thing. That was a common finding. The first one is there's no difference in overall survival, breast cancer-specific survival, but there is a difference, a significant difference in local relapse rates. So surgery is superior in local control, but this does not translate into an overall survival. Let's concentrate on the only trial which uses the inclusion criteria as just having the patients with an ER receptor-rich patients. This is the Nottingham 2 trial, which included the patients with mastectomy and tamoxifen versus tamoxifen. And at the end, again, they found that only 3% of the patients have the progression. And when they had the impact of this, the efficacy of this treatment in the first 6 months, and most of the patients remain as a responsive. And at the end, nearly half of the patients remain in response, although they stopped using tamoxifen in the first 5 years. And this study, although says that they included patients ER-rich tumors, but when you look at it, this H index, H score, they included patients over 100. That means the upper limit is 300. So they made a secondary analysis in the prospective cohort, and they divided their patients into 2 with an H score over 250, and they compared it with those with an H score less than 250. And they found there's a significant difference. So those who were really rich, that means that you can say that's over 80% of ER positivity. There's no difference in the surgery and primary endocrine therapy, but not in local control means. This is, again, breast cancer-specific survival. But this just gives us an insight that if you have a cancer with a high ER content, in the receptor content, so the endocrine treatment would be more effective. That doesn't mean that should replace surgery in all patients, because all these trials only included fit patients. So, also another question is whether to use AI instead of tamoxifen in these, because all these 3 trials use tamoxifen as the adjuvant treatment. So a beautiful review from UK, published in 2014, they included more than 15 studies, but these studies are all prospective or retrospective cohort studies, not randomized studies. And this systematic review showed us that if you use aromatase inhibitor instead of tamoxifen, you would have something like 10% more effective than using tamoxifen by means of complete response, partial response, and stable disease. Therefore, the rate of progression is less when you use aromatase inhibitor. So, as an interim conclusion, the applicability of using a primary endocrine treatment, well, for today's contemporary use, we can say that this is an AI. You can use it in frail patients because it just gives nearly half of the patients have a response on this in HR positive, hormone positive patients. Also, regarding that the surgery is safe in fit elderly, then because we know that perioperative mortality is 0% in these trials, so that shouldn't replace surgery in these patients whenever it is possible. So the second issue is the partial mastectomy without whole breast irradiation. There are two studies included, only patients who are over 65, and they are all node negative, clinical node negative. One is pathological node negative, all small tumors, and all ER positive, hormone positive tumors. Every patient had a lumpectomy with R0 resection, and every patient used tamoxifen 20 milligrams per day for 5 years. Again here, we have the result as we had it in primary endocrine treatment. Whether you use a radiation treatment or not in these patients, you have no difference in overall survival or breast cancer specific survival, but you have a difference in local relapse rates. So here is the longest follow-up, the CalGB trial. After 10 years, they found that the absolute difference between arms is 5%. And the second trial, which is the PRIME2 trial, the UK trial, showed us with the shorter follow-up, they have a very good overall survival, which is over 90%, and the 5-year in-breast tumor recurrence is something like 1.3 in the radiation arm and 4% in the tamoxifen arm. So the absolute difference is something like 3%, as you can see. But in a subgroup analysis, they showed that if the tumor is highly rich in ER content, receptor positivity, this difference is getting small and small. The ones with an ER poor status, the absolute difference is increasing up to 10%, but in those with the ER-rich tumors, it is something like 2%. So there is a validation study from Sweden. It's 14 centers. It included patients over 65 years. These are, again, low-risk tumors, non-lobular grade 1, 2. They made, again, R0 resection and made a sentinel lymph node biopsy and proved that this is a node-negative patient. And they used aromatase inhibitors as well as tamoxifen. After follow-up of something like 70 months, they found that in-breast recurrence rate is 1%. And the overall survival is 93%. So this is one-arm, non-randomized study that shows us that it would be feasible in these patients if they are in low-risk status. So the applicability, well, frail patients would omit radiation treatment after breast cancer surgery, of course, or if they are fit, if they're clinically low risk, that is over 65 years of age, grade 1, 2, small tumor, luminal A, again, considering the absolute gain by giving the radiation treatment, you may consider not giving radiation treatment. And sentinel lymph node biopsy. Dr. Veronesi showed us beautifully, but did not report the latest results in their trial. Sound trial will be showing us, because they included all age groups over 18. But as we saw on the slides, 35% of the patients are the elderly patients. So this will give us an idea about this situation, and specifically in this, not maybe specifically in this elderly age, but we may have an idea about this. But it is true that in this elderly age group, it's not we see high proportion of patients having node positivity. Overall rate of node positivity in this group is a little bit lower than the younger ones, and it was reported in several databases around 15%. But if you consider only those low-risk ones, which are grade 1, less than 2 centimeters, or grade 2, less than 1 centimeter, the likelihood of having a node positivity is below 8%, and this was also verified in various databases, including the Austrian one. So there are 2 studies with not reflex the sentinel lymph node biopsy, but comparing axillary dissection versus no axillary dissection, and they showed, again, the same thing. No difference in overall survival, no difference in the breast cancer-specific survival, only local control is a little bit bad, worse in those who didn't receive axillary dissection. And all these patients had either mastectomy or breast-conserving surgery, and most of them, again, are ER-positive tumors. One study, which is retrospective from the US, showed us that with 104, this is a database report, with the small tumors, it's clinical node negative, breast conserving surgery, only 75% of them received the radiation treatment, and most of them are less than 2 centimeters, and almost all of them are hormone positive. And at the end of 5 years, they only found one recurrence, and that was in a triple negative cancer. And the 5-year breast cancer specific survival was found to be 96%. So here the critical question is, if in your practice you would like to go on with a sentinel lymph node biopsy and it turned out to be a positive, will you consider to do an axillary dissection in these elderly patients? Will you consider to give a radiation treatment to the regional nodes? And will you consider to give chemotherapy in these patients? If you say no to all these questions, then is there any reason to do sentinel lymph node biopsy? This should be a critical question when deciding the treatment in here. Because we know that. It's a very beautiful database result from the US again. They show that if you have, whether you have a node positive or negative, if the patient is hormone positive, HER2 negative, and in these patients, they show that the mean recurrence score, 21 gene score, is almost the same whether you have node positive or node negative patients. So this shows us that the main critical thing here is not the node positivity, maybe the biological factors that we can have from other parameters. So the applicability is all 5 patients, we may omit maybe, and the fit patients, if in those that lymph node information will not make you to change your treatment, or those are low risk. Of course, after having a sound trials result, we can be more sure about this. So what about the impact of age? Very few studies on this. And first, there are 2 things. There are competing risk factors. Never forget about this, because we know that more than 2/3 of the patients are dying not because of breast cancer, because of those other reasons like cardiovascular disease and dementia. And in fact, as the age advances, this numbers is increasing. It was showed by 2 beautiful studies from Nottingham Registry and the Leiden University from Netherlands. And the focus cohort study from Netherlands again showed us that the number of comorbid diseases associated with the all-cause mortality, and the meta-analysis from the Denmark from 18 studies showed us age is not the real factor, but the comorbidity is the independent factor for poor overall survival in these patients. So age is related with comorbidity, but comorbidity seems to be a more important factor. Again, the physical limitation is the independent factor for poor overall survival in one of the studies showed in North America. Not the age, not the cancer stage, not lifestyle. And for the surgeons, for the post-operative complications, I showed that it's increasing by age. Again, the independent factor is not the age, it's the number of comorbidities, which is not surprising, and the polypharmacy that you're using for these diseases. And when we come to the biology, the Toronto, British Columbia trial, comparing the patients who received the whole breast irradiation after breast conserving surgery to no radiation, but they included patients over 50 years of age, but they made a subgroup analysis with a limited number of patients, and this is 265 patients. They stratified according to the intrinsic factors, and they found that the relapse rate, in breast relapse rate, is not related with the age, but the grade and subtype. They show that in luminal A tumors, the absolute decrease or absolute difference between treatment groups is 4%, and they didn't find that this is significant. And again, 7 trials they made on DX score, Oncotype DX, which are less than 18. They show that, again, hormone status, Oncotype DX recurrence score, and the age were found to be factors. But this study did not make multivariate analysis. We don't know which one is the independent one. And Dana-Farber, Brigham, Women's, and Mass General showed us that as age advances, we see less local recurrence. In the 8-year local recurrence rates is something like 3%, around 3%, who are older than 50 years of age, and all these patients have received radiation treatment, none received trastuzumab. And in their previous report, this cohort showed us that even in luminal A tumors, in each subtype, in time, as the age, when you stratify according to the age, still in elderly patient groups you see less recurrence. This is true in luminal A as well as in triple negative patients. So another final study is from, again, North America. This is a non-selective group with nearly 4,000 people. They reviewed 9 data sets which had the genomic analysis and microarrays, and they showed again, because this study does not give any details about the surgical treatment in these, is not associated with recurrence-free survival. So the independent impact of chronologic age seems small. So as a conclusion, we must consider relevant outcomes and endpoints for elderly. Sometimes their priorities are different than ours. So we have to sit down and make a balance between their expectations and our expectations. And also perform geriatric screening is very important, but these are very simple things that you can implicate in during your daily life. If the screening says there's a risk for these patients, you can go on with an assessment. And de-escalation is not out of option in those fit with low-risk cancer, but it is up to you. We can't say that you have to do, and you should respect patients' expectations. And most important of everything, is that you have to make a collaborative effort to decide what to do for your individual patients. So collective decision-making should not be out of option here. Thank you very much for your attention.
Thank you very much, Dr. Gulluoglu. We just discussed with Dr. Gulluoglu because the time limit, we probably made all the discussions in the finals.